Hi everyone, my name is Rochelle Giavendra, and today I'll be talking about our QI initiative, which is improving peripheral artery disease screening in high-risk patients. Peripheral artery disease affects about 8.5 million Americans and is a significant marker of systemic atherosclerosis, with a 5-year mortality rate of 33.2%. Despite this, PAD still remains underdiagnosed in outpatient settings. Underdiagnosis of PAD in primary care settings is a significant issue and poses a challenge when 20 to 50% of PAD patients are asymptomatic or have atypical symptoms. While the AHA-ACC guidelines recommend measuring resting ABI in patients with features of PAD on exam, the guidelines now indicate that it's reasonable to test resting ABI in those with increased risk of PAD, even though they don't have features of it on examination. Given this data, our aim for our QI project was to increase PAD screening and documentation in the community resident clinic by 20% in 6 months. A root cause analysis was conducted so we could identify the factors that lead to underdiagnosis of PAD. When we look into healthcare workers, lack of awareness of PAD symptoms or screening guidelines, and sometimes even the inadequate training in ABI measurements can lead to underdiagnosis of PAD. In addition, short clinic time visits limit thorough vascular assessments, and ABI testing not routinely being triggered for at-risk groups can lead to underdiagnosis. When we talk about systems, lack of reminders or alerts in the EMR system, and the fact that there are no incentives or quality metrics tied to PAD screening can lead to underdiagnosis of PAD. When we look in our environment, there is no streamlined referral pattern for when it comes to seeing abnormal ABI results. So while we do have the abnormal results, we don't know what the next steps are and what algorithm to follow. When it comes to patient factors, patients minimize or do not report atypical symptoms. Patients also may have mobility limitations or other comorbidities that mask claudication symptoms, which can lead to underdiagnosis of PAD. And finally, when it comes to equipment, lack of access to ABI machines in the clinic or lack of supplies for ABI testing, such as cuffs and Doppler devices, can lead to underdiagnosis of PAD and should all be considered. Using the IHA model for improvement, a quality improvement project was initiated and guided by the PDSA framework, where we identify screening barriers through root cause analysis as well. We created a survey for the residents to assess their overall knowledge of PAD, practice attitudes, and compliance with screening. Following the final survey results, we developed a detailed plan to address the top barriers to PAD diagnoses. In our first PDSA cycle, our focus was to increase awareness. Through this, we conducted an educational session for residents on the importance of PAD screening, particularly for asymptomatic and atypically symptomatic patients. We then assessed improvement in knowledge, attitudes, and practice using a post-intervention survey. Pre- and post-intervention knowledge was assessed with the following grading scale. If you scored 85% or greater, that was considered excellent understanding. If you scored between 70 and 84%, that was considered good understanding, 50 to 69% basic understanding, and if you scored less than 50%, you got a needs improvement, and this was correlated with the number of corrected responses you got. Among our 38 residents, 32 submitted a survey response, and 30 of them fully completed the surveys. Baseline knowledge assessment indicated a good understanding of PAD, with a mean score of 79%. Post-intervention, after education, the mean score increased to 85%, reflecting an excellent understanding and improved competency. Confidence in identifying PAD risk factors and their symptoms also improved. In the pre-intervention, 26 residents felt somewhat confident, while 4 of the residents reported feeling not confident. However, post-intervention, 23 of the residents felt confident, and 7 of the residents felt very confident in identifying PAD risk factors and their symptoms. Primary barriers to PAD screening included lack of time during clinic visits, limited access to ABI diagnostic tools in the clinic, and insufficient awareness of PAD guidelines, which were reported by 19 of the residents. Following intervention, 23 of the residents reported that they were performing more PAD-focused physical exams, such as pulse checks, and all of the 30 of our residents that completed the surveys did report that the educational session increased their awareness of the importance of PAD screening. As we can see here, before the educational session, the pre-intervention showed 79% in terms of PAD knowledge. However, after the educational session, the post-intervention survey showed 85%, an increase about 6%. Before the intervention, we had residents feeling not confident to somewhat confident, and after the intervention, they reported being either confident or very confident at the end of the educational session. In conclusion, the educational intervention significantly improved residents' understanding of PAD, enhancing their confidence in screening practices during routine physical exams. Increasing screening rates and timely referrals will help reduce PAD-related cardiovascular complications and improve patient outcomes. For our subsequent PDSA cycles, we hope to perform more hands-on training on ABI measurement and provide standardized screening protocols per AHA guidelines and ABI diagnostic tools in the clinic. We want to also focus on enhanced documentation and will develop strategies to improve PAD-related documentation in the EMR, such as system reminders and continuous education sessions on improving sustainability. And finally, we want to work on referral optimization to create a streamlined process where we can establish further diagnostic testing and specialist consultation in patients with abnormal ABI results. That's it for our QI project. Thank you so much for listening.